Now to our main program. We will hear from Philip Welkhoff of the Gates Foundation, and Jeff Pritchard will introduce him.
Thank you, Kim. The malaria parasite has inhabited this planet for over 1 million years, and during that time, it has been the greatest killer of mankind. Today, despite all our advances in logistics, in technology, in medicine, malaria still claims the life of over 400,000 people every single year, and most of those are children. Philip Welkhoff is the director of the Bill and Melinda Gates Foundation's Malaria Program, and in that role, he oversees the strategy and its implementation of the Foundation's malaria work. And I should mention that the Foundation, to date, has invested over $3 billion in that effort. Prior to joining the Foundation, Philip was the director of research at the Institute for Disease Modeling. And as that name implies, that work involved creating computer models and computer simulation around malaria transmission to help aid in its elimination. Philip received his 2 undergraduate degrees in aerospace engineering and mathematics from the University of Texas, and his PhD in applied mathematics from Princeton. And before I forget, I should point out that Philip's wife, Martina, is joining us today to hear Philip. So, Philip is widely regarded as a thought leader in the global health community, and he's written a number of academic reports on that subject matter. And for any of you who are linguistically inclined, Philip speaks a number of languages, including Haitian Creole. Here to update us on the fight against malaria and why it's so important, please join me in welcoming Philip Welkhoff.
Fantastic. Thank you, Jeff. Thank you, Kim. And thanks to all of you for the opportunity to be here today. So when I was approached with this opportunity, I said yes in an instant because the legacy of Rotary International and of Seattle 4 is just so strong. The legacy as a global force for good. I think this manifests in many different ways. Most of all, in terms of the way that service for those most vulnerable and those facing some of the toughest challenges in our communities, in our countries, and around the world. There's been sustained effort to actually improve health systems around the world and in wherever we are. And tremendous work to improve capacity of health workers, extend services, and make sure that those who need access to care actually have that access. I think we're on the verge of tremendous success in ending polio for good. And I think if you think about how much progress has been made over the last several decades, none of that would have been possible without the leadership, without the resources, and without the engagement of Rotary International and Rotarians and clubs all around the world. And personally, this was a tremendous pleasure to be here and a privilege as well, because one of the reason I speak Haitian Creole is growing up at a small humanitarian hospital on the north coast of Haiti. And the water systems in that part of the country were actually put in by Rotary International clubs around the world in association with 2 local clubs in Haiti. And so, I grew up drinking water from water systems that had actually been put in by Rotary and Rotary partners, which is just, coming full circle as far as that goes. So it's been over a century of engagement. And it was remarkable to see that a club that you helped found and establish is now reaching its century mark as well. So turning to malaria, this is a critical moment in the fight against malaria. So just a bit of context. There was an effort to eradicate malaria that was launched in 1955. And for 14 years, it made substantial efforts to drive down malaria. It actually cleared out malaria and achieved elimination in a number of countries, and saved quite a few lives over that interval. But they ran into some real challenges, both in terms of the logistics and the intense transmission in Africa. They ran into challenges of the mosquitoes becoming resistant against the insecticides that were being used, and how long it actually took. People didn't realize that it was actually when they were 14 years into it now, the hope had been that they would be able to drive it down quickly and achieve a faster win. So it got put on pause, burdens started coming back up. Through the 80s and 90s, the main drug that was used to treat malaria, and I took that quite often growing up in Haiti because when I got malaria, resistance to chloroquine spread across much of the world. And as we lost the drug, and malaria is a terrible disease. The fevers come on fast. There's not much time to actually get to a health facility, especially if you're a smaller child, or especially if you're a smaller child that has had other health challenges or is poorly nourished. Malaria can be very devastating and kill very quickly and unforgivingly. And so when the drug that was being used to actually treat this failed because of the parasite developing resistance, death rates, which had still been on the way up since the end of the first big global program in 1969, started increasing quite rapidly through the 1990s as chloroquine resistance spread across Africa especially, peaking at well over 1 million deaths a year in 2003. Fortunately, the world came together. There were increasing in funding. There was new efforts like the Global Fund Against AIDS, Tuberculosis, and Malaria. New tools were rolled out, drugs that worked, the artemisinin combination therapies. I know that this is a very global health literate group, but if I use a acronym, just call me out on that. Artemisinin combination therapies that were working, rapid diagnostic tests to actually extend diagnosis of this is actually malaria out to every point of care. Insecticide-treated bed nets that not only blocked mosquitoes from biting people, but actually killed mosquitoes so that they couldn't go on and infect others. All driven by a big increase in funding. These things weren't cheap, although they've become cheaper over the years. And with this big increase in new tools and a strong increase in funding, malaria got driven down, and in the most recent statistics, which we have is the last year's World Malaria Report for 2017, deaths were down to 432,000 a year. So on the one hand, that's tremendous progress, because from over 1 million now to just under 500,000, every year we're saving more than 500,000 lives through the work that the international community does, through partners, through funders, through implementers, through intense work from national malaria control programs and frontline health workers. However, the other side of that is there's still almost 500,000 lives being lost every year. And here's where the critical moment is that progress, where from 2003 onward, with the increase in funding and the rollout of new tools, we actually drove progress every single year, and every year was marked by a sustained and rapid decline in both cases and deaths. The last few years, it's been flattened out. Global funding for malaria has been approximately flat since 2011. While it took some time for that flattening in funding to turn into a flattening of impact, that's shown up. And even worse, we're now starting to see that the tools that have driven so much of that success, we're starting to see both the mosquito and the parasites evolve resistance against those as well. So right now, we've made a lot of progress. We're saving more lives than ever before. I think over the last 15 years or so, we've probably saved, the estimates are tough, but we've probably saved over 7 million lives, which is a remarkable accomplishment. There's so much more to go. And in this moment, it's becoming harder just to run in place. And that running, we're working harder and harder every single year just to keep the deaths from going back up, and the deaths are still extraordinarily high. In addition to that, malaria is an unforgiving disease. Anyone who's been in a place where when it gets warm and puddles all over, and you know how fast mosquitoes can pop up, and the swarms there. In a place with malaria, mosquitoes, and poor access to health care, malaria comes back very quick in a very unforgiving way and causes cases and deaths. One of the most recent examples of this was in the West Africa Ebola outbreak. Very hospitable conditions for malaria, total breakdown of the health system due to the outbreak, and also the inability to sometimes distinguish the first fever of is this malaria or is it Ebola. And the current indications from that outbreak are that we probably had quite a few more deaths due to malaria than due to Ebola during the outbreak at that point in time. And so as long as malaria is in these communities, as long as we don't actually get rid of it all the way, we're going to be facing challenges where every time something goes wrong, there's a offset in funding or conflict, unrest. We see what's happening in Venezuela right now. We can get tens of thousands of people on top of that near 500,000. That is just the baseline, what's happening. Every time something goes wrong, we lose tens of thousands more. So progress is stalled. There's a need for urgent action. And just to drive this forward, because I think the service and those most affected and most vulnerable is a key priority for all of us. Malaria is one of the key indicators of and drivers of inequality around the world. I think if you look at malaria there are some diseases for which we're looking for cures, we're trying to discover treatment. I think we should never forget that malaria is preventable, it's treatable, it's curable. We have the tools to prevent transmission, we have the tools to diagnose it when it happens, and we have the tools to treat it after a diagnosis. It's about making those things available. It's about making sure that people have access to it. So if you were to come down with malaria with good access to a clinic, good access to health care, you can very quickly get treated. You can very quickly fully recover without longer effects. If you don't have good access to care, this fever, you might, say you're a child growing up, your parents might not take you because it might be a half day or more to get to the health facility. Getting to the health facility, the right drugs might not be in stock. There might not be the right diagnostics. And that actually then results either in death or a sustained infection. And malaria is immunosuppressive. Malaria weakens the bodies, and one of the things that we see, which is both it's both an encouraging thing and also it shows the magnitude of the challenge. When Sri Lanka made massive decreases in their malaria burden, total deaths fell by more than twice, about twice. It depends on exactly how you count it. Total deaths fell by about twice as much as the malaria deaths they expected. Turned out that deaths due to pneumonia and a number of other factors went down also. Because it turned out that bodies that weren't being weakened by malaria were better able to fight off all kinds of other infections. And so not only are we thinking about the over 500,000 deaths that we avert every year due to the activities, the 500,000 deaths that are still remaining, but we think about all the other deaths, especially in children under the age of 5 or without good access to health care, that we could be averting as well. So it's where you see malaria deaths, it both is a sign of the inequality that exists and also continues to drive and exacerbate that. Despite all these challenges, there is some real reasons for hope. The first one is we're getting better data and we're getting better surveillance. We don't have enough global resources to do everything everywhere, but as we work on improving health systems and improving routine information and making sure that whenever someone has a malaria case at a clinic, they actually get diagnosed and that case gets reported to the Ministry of Health, we can actually work with countries to concentrate those available resources and tools where they make the most impact. There's a huge effort going on right now in collaboration with President's Malaria Initiative, Global Fund, World Health Organization, Rollback Malaria Partnership, to improve disease surveillance systems, improve information systems, improve the abilities and the capacities of national malaria control programs to act on that information, and where all the partners can come together and make sure that the nets get to where they're needed. Right now, there's in Ethiopia, there's about, if you look at the areas of the country where no malaria transmission happens, there's about 20% coverage with bed nets there. If we could actually use the data systems and partnering with the program there to make sure that those resources are deployed to where the transmission is actually happening, you could actually drive down transmission in a very aggressive and effective way where the malaria burden is actually most concentrated. So these, in the face of limited resources, the improved data systems, it's not just knowing more for knowledge's sake, it's not just having better data of what could have happened, it's actually working with programs in an operational and effective way to do better with the tools that we have available. But we don't just have the tools that we have available. Every year, or every 2 years, we are getting new tools in our toolbox. There was just last year approved a new cure for the full treatment of Vivax malaria, which is the relapsing one that hides out in the liver and keeps coming back multiple times. We have good effective treatments for whenever it emerges from the liver and starts that blood stage infection. We didn't have a very effective treatment to actually clear it out of the reservoir in the liver. We do. I mentioned that our current tools, the bed nets, doing a lot of the heavy lifting. We're facing evolution of resistance among the mosquito populations, and they're becoming less effective than they were. That too is changing. We have new active ingredients on nets, and those are being rolled out. And this flatlining of funding, we may be getting some good news on that as well. This week in Lyon, it's expected that there will be an announcement of the Global Fund replenishment, which is likely to be the most money ever raised for fighting tuberculosis, HIV, and malaria. So we've made a lot of progress. We've made a lot of progress. We have a long way to go, and we have some reasons to hope that we can get there. And within all this, the partnership with Rotary International and with Seattle 4 is really special and important. While the partnership on malaria is new, the partnership and collaboration with Seattle 4 has been going on for a long time. We think a lot about the leadership of Bill Gates Sr., who's so influential in driving forward the Bill and Melinda Gates Foundation, and also want to remember just the passion, the legacy, the activity of Steve Crane. Seattle 4 member, executive director of Rotarian Malaria Partners. Conversations with him earlier this year were a big reason why I'm actually speaking with you today. And we all miss him and remember his legacy and the work that he was driving forward and that the rest of us are continuing to carry on. To succeed in this next stage of the fight against malaria, we're going to need a wide range of partners. Malaria is a very interdisciplinary problem. It shows up in many different communities, and there are many different aspects to the fight against it. And we're going to need partners who are ready to rise this challenge with innovative solutions and sustained efforts, and basically partners like Rotary. And Rotary's mission-driven philosophy, the knowledge of the affected regions, the technical expertise, and the demonstrated commitment to service position it to help get the world back on track for driving down the malaria burden and actually getting it all the way to zero. As we get these new innovations that I talked about, and there's a lot more in the pipeline beyond the new nets and the cure for liver stage malaria, your examples and your leaderships in resource mobilization and making sure that things actually get out to the most remote communities in the weakest health systems and to the most vulnerable and affected populations are going to be essential to actually making sure that we get all that's possible out of these new opportunities. And this is already happening. I think you've heard a lot about the activities that Rotarian Malaria Partners are doing in both Uganda and Zambia. It's been remarkable to see the engagement of communities, the engagement of advocates, the engagement of partners at all levels of society, and in the capital all the way down into the communities where the malaria is most concentrated. And progress is happening, and so we welcome this continued partnership. I'll just close by saying that despite the current challenges, despite the magnitude of the lift that remains, malaria eradication remains our North Star. This is something to which Bill and Melinda have made big announcements and commitments to starting in 2007. But this continues on, and we actually see the whole global dialogue around malaria changing. There were just 2 big reports, one this Strategic Advisory Group on Malaria Eradication of the World Health Organization, and also the Lancet Commission on Malaria Eradication, with both in the last few months, came out with strong findings that eradication needs to be the global vision for malaria, getting to a world completely free of malaria, that there's no biological or technical impasses to, like a intractable animal reservoir that would keep us from getting there. But at the same time, we need sustained innovation of new tools, we need improved financing, we need improved systems. So we have a clear goal. We have a lot of lessons that we've learned from malaria and a lot of lessons that we need to learn from polio. And I think that's another really important reason and benefit of this partnership is because of the leadership from the 1980s onward in terms of setting the goal for why we need to get rid of polio, what's possible, how can communities come together, how can the logistics happen, how can the tools be delivered to the right place and at the right times. We're going to need those same lessons. We're going to need that same discipline and that same sustained effort to get rid of malaria. But it's actually doable, it's accomplishable, and very excited for the work that's been accomplished to date. Tremendously grateful for the service for making lives better around the world and for the work on polio, and very much looking forward to the continued partnership with Rotarian malaria partners and others on pledge matching, collaboration to deliver treatments, and sustaining and expanding the fight against malaria. So thank you all very much. So I believe we have some time for questions, and there's a couple people with microphones. Yes, and here.
Did you say that there's a spike in Venezuela right now?
Yes. We don't have the exact numbers because some of the unrest and challenges with the system make it difficult to actually get the numbers. But we are seeing a big uptick in both Vivax and falciparum malaria. Falciparum malaria is the one that causes the most deaths worldwide. It had been quite suppressed across much of the region, but there's now a big increase. And with a lot of people leaving Venezuela and going into Colombia, Brazil, Guyana, we're seeing upticks in the neighboring countries as well, driven by this. So it's getting very close to humanitarian disaster territory if it's not there already. And this is one of those things where malaria increases exponentially fast when you have the right conditions. And if you don't have the system and the health systems in place to break it down. And the conditions are right and the systems are not. It's a major challenge right now.
So my uncle, Joe Crane, who was a Rotarian, contracted malaria when he was in Guadalcanal with the Marine Corps. And he had the type of malaria that was in his liver, and it would come back for his whole life at various times. Is this a common form of malaria? Because other than him, I had never heard of it.
Yes, so there are several forms of relapsing malaria that stays dormant in the liver but comes back and creates new infections. And the one that causes the highest burden is Vivax. It doesn't kill as many people as falciparum, but it causes hundreds of millions of, it most likely causes hundreds of millions of cases. It's sometimes hard to diagnose. It's a major health problem, and it's the biggest and most dominant form of malaria, both in Latin America and in the Asia Pacific, including the Solomon Islands. It is that form of malaria that we now actually have a new effective treatment. The previous treatment was primaquine, which required 14 daily doses and some luck to clear out the liver. Why 14 days of treatment? It turns out that was how long it took soldiers returning on ships from Korea to San Francisco. And so they would just treat them the whole time they were on the ship and hope that was enough, and that became the standard treatment. We now have a drug that with a single dose and a single encounter can actually completely clear out the liver stage to make sure that it doesn't keep coming back afterwards.
Thank you for being with us today. Could you comment a bit more on how climate change is impacting this flight and warnings or earnings against that?
No, absolutely. I think climate change is one of the biggest challenges of our times, and it is completely tied to to all kinds of things in health and in our ability to respond to it. So malaria is affected by weather patterns, by temperatures, by rainfall, and climate change will cause disruptions and changes to all of those. It also, to the extent that climate change is going to affect the food and farming systems, being well nourished is an important part of being able to survive and against malaria infection as well. So we see this fighting malaria as such a multidisciplinary, so many different sectors have to go right, and climate change is going to be affecting all of them. And so, yes, we are very focused on what needs to be done to get ahead of that, and that also adds real urgency to actually getting rid of malaria, because I mentioned that whenever something goes wrong, tens of thousands, if not more, people die. This is something that's we know is going to go wrong, and so it increases the urgency of getting malaria to zero as fast as possible ahead of time. Oh, yes.
About 10 years ago, I was privileged, actually with an encouragement of Steve Crane, to visit the display at PATH on malaria. I was interested to find out that one of these centers for fighting the disease is in Seattle. But that aside, one of the things I learned was that it's not just simply malaria. It morphs into different forms. And so when you treat one aspect of it, you may not affect the others. I imagine that complexity is a huge challenge in trying to find a cure.
Very well said. One of the earliest and I think best analogies for malaria came out in the 1930s. There was a famous malariologist named Hackett. And the way Hackett described malaria is like chess. I said there's a fixed number of pieces, fixed number of rules, and almost uncalculatable complexity that comes out of that combination of pieces and rules. And we deal with this quite a bit in many of these different settings, because you can't just say, here's the one thing you have to do worldwide and you're done with malaria. It takes a real understanding of the challenges, understanding that when you affect one part, what else do you need to do to actually succeed? But yes, the complexity is high. Despite that, we've been learning a lot, and I think have some effective plans for driving forward the success and getting all the way to zero. Oh, yes. Yes, very good to see you.
I had a friend who went to Africa and took, I guess, the appropriate drugs beforehand. And she contracted malaria and got very sick. If we're thinking about going to those areas of the world, what should we be taking and how effective are they?
Yep. So fortunately, we have a variety of options available for malaria prophylaxis for traveling. Each of them is a little bit different. So for example, Malarone would be the top choice. Some people take mefloquine. Mefloquine you have to take for a couple weeks ahead of time to make sure it actually gets to a sufficient concentration. Otherwise, if it just starts while you're there, it might not be at a high enough blood concentration to fight off the malaria. And also it has side effects. So Malarone with the appropriate dosing and making sure to take it at very regular intervals is probably the best option for the prophylaxis. And it should work, but it takes a really diligent focus on making sure that the timing is right.
Thank you for your presence is very felt in the room, I know. We've had some successes in the fight against malaria, especially in Zambia and especially in the southern provinces. Without going into this question anymore, I wondered if you could talk a little bit about those successes and how you did it and what's the future.
Absolutely. I can talk about the malaria fight in Zambia for a couple hours, so I will keep that to about a minute. There was a sustained effort that started at many different levels. At the national level, the national program, with a lot of sustained partnership with PATH, actually, there was a cultivation of a strong leadership cadre that drove good decisions and good policies for the whole country. There was sustained engagement all the way down to the every community level in Southern Province. There was good engagement of civil society, faith-based leaders, and others who actually would go door to door and explain, here's what the malaria program is doing, here's how we're actually going to fight it, and here's why the drugs that you're getting are actually going to help. It was a remarkable effort that covered all those different bases, and the results that came out of that took one of the southern province on the shores of Lake Kariba from one of the highest intensity burdens in sub-Saharan Africa down to where there's almost no malaria left. There was good access to care, good deployment of the right tools, and the right leadership and community engagement at each level. So it is certainly a blueprint for scalable success.
Last question. Philip, can you say more about the lessons that we learned from polio and applying those to malaria? And in particular, I'm interested about the opportunity to redeploy the energy and resources that were allocated to polio to malaria.
Fantastic. I think there's a couple pieces within this. We updated our Gates Foundation malaria strategy last year with the new strategy being approved in December. And the lessons from polio were one of the key inputs to the whole process. One of the first ones is that successive eradication of the disease is driven by the hardest countries, the last countries. On polio, we see the efforts that were required in India, which succeeded, in Nigeria, which has now been more than 3 years without a wild polio case, which is a remarkable accomplishment. Pakistan, Afghanistan, where the fight needs to be successfully finished in that one section there. So as a result, we're actually beginning ahead of time with engagements in what we know will be the hardest places. If you were to take a room full of malariologists and give each of them kind of 5 pieces of paper and say, write down what you think the last 5 countries with malaria are going to be, it wouldn't be a long list. Nigeria is going to be there. Democratic Republic of the Congo is going to be there. These are places where we need to be starting to engage now, building up the leadership in the malaria programs, building up the surveillance systems, building up the logistics capacity to get tools where they're needed. And the other thing is that the investment in data and surveillance systems, being able to find out where the disease is, first for polio and now for malaria, and then respond to it rapidly. And then the continued innovation. If you think about and innovation not just of new tools, but of ways of engaging communities, of doing logistics, of using data, I think there is a blueprint that polio has written for us that we can follow. So thank you all very much.